Good evening, everybody. Welcome to the Pure Urology group. As you all know, Pure Urology is the largest platform for learning surgical techniques, which we have initiated 5 years back in the same month during the pandemic period in 2021. Later on, after the pandemic is over, we continued with the focus on surgical techniques. Now, Pure Urology is a 12,000 members group. Today, as a part of this Pure Urology, myself, Dr. Chandra Mohan Vaddi, is talking on the enucleation of the prostate, unedited video. This is not live, but I have recorded live without any modification. So I will play the video, and in between I will stop and take the questions. Honestly, over a period of 22 years, I felt that TURP is a very good surgery. Holmium laser enucleation is very costly. In private practice in India, buying 1 crore mission is not cost effective. So when I purchased TFL 45 watts, I used to do with TFL. I have shared video also. I might have done 20-30 enucleation with TFL also. 1 joule and 10 Hz was the setting. Everything looks good, but capsule is not well defined. And second thing, whatever the tissue that comes in your laser, it will cut. So you can finish the surgery, but you don't appreciate without applying the mechanical pressure. Many of the conferences we see that in HOLEP, the plane develops automatically because of the basic mechanism of action of the holmium is large bubbles. Now, I purchased recently 160 watts holmium laser from Potent, and I started doing all the enucleations with holmium laser. Definitely there is some difference, and that difference I am able to appreciate. After doing 10 cases, I thought my initial experience I will share with unedited video. Once again, I thank all the speakers. Last 5 years, 380 topics have been done. Lot of feedback came from the juniors that it is useful for the examination preparation as well as for the surgeries also. That gave me enthusiasm, not only to me, my team, Preeti Kidney Hospital, audiovisual team, consultants, all are habituated to record and try to present and try to do the interviews also. With this introduction, I will play the video. I have taken the initial equipment as well as the laser settings also. So I am sharing the presentation now. So Bloc enucleation and morcellation for large BPH, that is 160 watts holmium laser unedited video. Actually 160 watts I have not used. I have used only 100 watts. This is the video I am playing. It can be adjusted back. In between I will show where is 5 o'clock, 6 o'clock. The problem is those who have come in the middle, they cannot follow easily Bloc resection. So I am playing here. In between I will stop and talk. If any questions are there, you can take in the chat box. I will be watching by the side of my screen. And this is the picture. I am starting the video now. Bloc enucleation and morcellation for large BPH. 63-year-old male patient, obstructive LUTS 2 to 3 years, prostatomegaly, history of asthma, hypertension, grade 3 enlarged prostate, firm. Dear urologist, today I am sharing the surgery, that is Bloc resection of the prostate with Holmium laser. As you all know, TURP is the gold standard, but en-bloc resection has also come into the limelight recently for larger glands. Bipolar enucleation, thulium fiber laser enucleation, and the Holmium laser enucleations are three methods. In bipolar enucleation, the problem is more mechanical pressure will be there. I have done few cases, technically demanding, I left it. Thulium fiber laser enucleation is good. In fact, for beginners, it is easy because it coagulates. But the problem is constant identification of the capsule is difficult. That is the main problem. Now coming to the Holmium laser, time tested, 30-40 years, costly mission, high wattage is available, 100, 150. Now today, the mission which I am using is 160 watts laser from potent company. Irrespective of the company, usually we use 60 to 100 watts. The same thing I am using. The reason to share this is I was struggling in getting enucleation surgery. So I thought I will share some common points where we do mistakes so that learning this surgery becomes adaptable to the youngsters. That is the main aim. So coming to the equipment, this is the equipment which is very important. The normal TURP working element has a loop attachment here, like any person knows it. Whereas the working element of the laser working element will be a laser fiber will come out through this hole, whereas here loop will come out. There is no difference. Coming to the sizes, I have 2-3 sizes here. One is 26 by 24, which is from the Coral Star. No conflicts of interest, I am telling. Second is 24 by 22 Wolf. Very good. Indian urethra, I like this for TURP, for enucleation of the prostate. Other one recently people are coming with mini hole, mini hole, ultra mini hole, where 2219 is very good, but vision is little tubular. It will take time. If the bleeding is there, it may obscure the vision. The best is 26 by 24. I am adapting to 24 by 22. Today in this surgery, I am using 24 by 20. Naturally, the scope is 4 mm only, no 2.9 mm. But this 22 by 19, this scope is small because in this channel it will not go. This is 2.9 mm. That's why vision will be little tubular. Now coming to the other equipment of the TURP, particularly Morcellation purpose, we have a nephroscope. From beginning I am not using Morcelloscope because it adds additional cost. So I am using nephroscope. That time I am changing the outer sheath whichever is suitable for this. This should be long length, and through this all Morcelloscopes will go. Apart from that, these are the morcellated blades. So with this Xenocan jelly, TUR said, normal saline is used, glycine is not used. But if you want to do monopolar coagulation at the end, glycine should be avoided. This is the primary. Coming to the laser mission, I have Dr. Hemnath with me here. In this hospital, we are using for last 1 month. This is, as I mentioned, from potent laser. Various other lasers are also available. Probably there is no difference. I am sharing my experience. There is a 2 columns here, normal and phenol, BPH. For BPH, we do soft tissues, this BPH and en bloc resection of bladder tumors. And if you touch this, you will go back to the stone. I am not showing any stone today. I will go back to BPH. Here on the left side is cutting, that is 52.0, total coming to 100 watt. On the right side, 32.0, total coming to 6. The major difference between these two is pulse width. In stone, pulse width, if it is long, it will not move the stone. But here, if the pulse width is long, it will coagulate. So pulse width in stone, long pulse width, no retropulsion. Enucleation or soft tissue, long pulse width is coagulation. Short pulse width is cutting. So we use cutting short pulse up to 100 watts. I have 2 morcellators. One is Coral Star, another is Biorad. This Biorad one is called Tomi. A Coral Star one name is, I don't remember, but I used for 3 years, very good. And this is also good. Good means it depends on the surgeon. This is appearing, suction is very good in this, so that I can catch the prostate. So with this introduction, I will start the case. Before I proceed with the case in this video, I wanted to say two important things. All of you know that for stone, 1 joule, 10 hertz. 1 joule is energy which breaks the stone. 10 hertz is the frequency which causes pulverization of the stone speed. Similarly, in enucleation, joule is the energy. When you use energy, it increases the depth. More tissue will be cut. Whereas frequency, if you increase, it fastly cuts. So when you are using energy at the sphincter, it should be reduced because depth will be more. When you are using in the sphincteric region, frequency should be low. When you are progressing in the middle part of the gland, you can use high frequency. When the capsule is thin, when large gland capsule is thin, immediately lower the energy. Don't say that one setting I will use forever. You should know the logistics. In the energy normally is 2 joules. I told 1 joule for the stone. 2 joules is the commonly used for the enucleation of the prostate. 2 into we have to change. 2 into 50, 100 watts is high, fast. 2 into 30 is 60 watts, medium speed. If you come down to 1.5 into 30, it becomes coagulation mode. To repeat, 2 joules is the optimum. 30 frequency is optimum. If you wanted to go high, you can go to 50 frequency. If you want to go, you can go to 30 frequency. This is what. Now I am demonstrating the endoscopic view of the surgery now. In between, I will stop and explain where we can go wrong, where I have gone wrong, where I have perforated, everything. Most important, we have the ultrasound also in the theater. This is from the Philips. We calculate this prostate size and planes before doing the surgery. Sometimes what happens, if you take 100 grams prostate, you will get 60, 70, that is normal, because calculations are based on the outside little bit extra tissue also. But when you truly enucleate, it will be smaller. So with this, I am starting the case and I will continue. Now, whenever you do any surgery, first inject Zelocan Zenvi, assess the penis size, and use Otis always. That too carefully because stricture may be there. So one person will hold like this, and then we rotate. Otis is primarily for submeatal region, but entire urethra also can be done. Adequate turning is essential. Rotate back and usually hold it here and clean, send for this cleaning immediately out so that it will not contaminate urinary tract infection like this. Now, coming to the scope now, I am holding it. Take the scope. Now you will take attachments. With the visual operator 24 French wolf scope I am taking to inspect the urethra and go inside. So now I am going inside with this QRZ, saline and water. And I'm starting here, and then white balance has to be done. Water on. With this water on, you can start this thing. Now this is the. So we are seeing the gland here. So in this surgery, I am exchanging the laser working element here. So now I will sit, and the laser fiber, please. I will sit comfortably. Very sleepy. So these things are important. So leak is because of the laser fiber, please. Laser fiber inserter here. There is a separate column here. Now you can see laser fiber coming out there. So this is the gland which is around mentioned 100 grams, but it may be 70, 80, small, medium lobe. I am showing the N block. The first step what we are showing is here is in front of the veru, everybody will give the incision. What incision? Inverted U incision or lambda incision. Here I am showing the inverted U. How this inverted U comes is, I am showing with the marking here. This is the inverted U. This is the inverted U. In front of the veru, if you do that, the capsule will be thin, the gland will be thinnest there. Directly you will go to the capsule. That's why we will go to that area, and then we will remove this marking. Now I am going ahead with the again presentation. So this is the inverted U. See, I am using 50 and 2.0. Normally submucosal bleeders will bleed here. You should not worry, you should proceed. See, I am taking time. This is totally unedited video. On either side, groove will be there. Slowly you concentrate on the floor, not on the roof. See, this is the inverted U. You got the inverted U here. This is the area already appearing like capsule. So that's not capsule. Any small yellow, which is considered as the prostate. So here you go, after some time, you will see small spaces, black spaces. That black spaces is the clear indication that you are entering into the outside the capsule region. Capsule is also not 1 millimeter. It has a thickness. See, same area I am doing repeatedly. The important point of, see, it is getting separated by itself. So you take pause, you think and develop the depth in only one area. I told you after some time, see, small yellow granules means it is, see here, I am going deep. I am going deep. See, there is one layer type of thing will come. That is the last level you should stop. It has not still come. The identification of the capsule is, see, now slowly it is lifting. Now the gland is over. I am coming, I am same inverted U. I am developing continuously. Still, I have not found the original capsule. See, there is separation. So some amount of gland is seen. Some amount of even stones will be seen. See, clearly I am concentrating between the 5 o'clock and 7 o'clock, 5 o'clock. Anybody can do this. Only thing is, submucosal bleeders will be there. You should be using slowly. If you do slowly, it acts like coagulation. See, same place I am rotating. I am not bothered about this sphincter. Little bit up to 3 o'clock I am going. 3 o'clock. 3 o'clock. See, small holes type of things will be seen. That see. That small holes type of things indicates that you are going just on the capsule and literally no bleeding. What I have seen is in this coagulation is also very good. So laser fiber a little bit vibrating if you observe. If you use a small laser fiber, it will vibrate more. That's why I am using 550 micron laser fiber here. See here, it is easily sweeping and one layer is getting up, entire prostate is getting lifted up. This lifting up will not be happening in thulium so easily. See, some black dot you can appreciate. Now I am coming up to 9 o'clock position. Like this, you should not do this for a long time. Because if you do like this, the anterior part of the gland dissection may be difficult. You do as much necessary. Even though some cases I had a problem, but overall I could manage so far without any TURP. See, same plane on the floor, automatically you will do it. Any small amount of yellow tissue, you can appreciate small yellow granule. That looks more brown in TFL. That is what I wanted to tell. See this small locule type of, see, this is a gland. This is a gland. Clearly protrusion is there. Even if you cut the gland, nothing will happen. But the thing is, this beauty will not be there. You have to come back a little bit. That is inevitable in HOLEP. Whereas in TURP, that is not necessary. You can stop wherever you want. See, I am rotating up to 9 o'clock. Now certain amount of the gland is pushed. See, same thing I am repeating slowly. Neither I have cut anteriorly. See, now if you come back, see how it is lifted up on either side. See, this is the mucosa. This mucosa can be cut like this, or this is at the right side of the patient. This is at the left side of the patient. This mucosa you are releasing so that a gland gets released at the 3 o'clock to 9 o'clock position. Now, see, some more mucosa I am releasing from below only. Again, I am doing capsule separation. This is the essential part. Once you do this slowly, rest of the surgery becomes easy. Now see, I am going anteriorly. Here trick is I am bending vertically down. I am applying here. This is the most difficult part. One point I am applying with that. No one can injure the sphincter with this square, with this one area cutting. It is only mucosal cut. See, mucosal cut. That should be beyond the sphincter. Now this is the blind part, like in PCNL. I am cutting the mucosa thickly so that I am releasing the sphincter region. You can appreciate I have cut between sphincter ke baad half centimeter. Then on other side also I am releasing. This release can be 1 centimeter beyond the prostate gland. See, 1 centimeter mucosa, it will slip off. Now reverse direction I am doing on the right lobe exactly. Now mucosa is released. What does it mean? Mucosa, if it is released, when you are rotating the scope, it will not cause pressure on the sphincter. Technically, now I have tilted. This is very important. Now why I am doing this is, I have tilted the scope up and made the laser fiber at 12 o'clock. Why? Because we are doing with 30 degrees. When you hit the floor, it will try to dig the small capsule. If you turn up, it will try to dig the prostate. So if given choice, whether to hug the capsule or whether to hug the prostate, you have to hug the prostate so that it separates automatically. Now I am hugging the prostate on the top. It is actually between at 6 o'clock. It is actually at 6 o'clock to 3 o'clock. See, there are capsule area, two different parts are there. This is again normal position I brought. Capsule I am separating. But as the time goes on, the laser fiber should be, see, now I have incised, I'm coming back. This coming back is the tricky part. This coming back beyond the veru, we are afraid. See, some part of the gland I am cutting because I don't want to go to the edge of the mucosa. No problem. Half centimeter, you cut it. These are all the initial hiccups we faced. Coming too back is a problem. Scope slips out. See, slowly I am going between. See, this is the prostate. Little bit tissue I have left behind here. No problem. You develop a plane which previously you have made. See, this is the capsule, no doubt. That yellow towards medial side. See, I am going through the gland. Now I came back. I am here. Literally, I crossed the veru. See, here. This is the most difficult part. You cannot get it by seeing the videos. You have to do it. See the arch. Everything is this arch observation. Benefit of doubt, cut through the gland, go to the capsule at the level of the sphincter, then damaging it. See, I am coming back boldly. I am cutting this bridge. I am going to the submucosal region, which I have given incision. Now I am playing horizontally. And now I am following the curve. All the gland is slowly moving away from me. This is on the right hand surgeon, left lobe of the patient. Left lobe of the patient. See, continuously I want to concentrate on the left lobe. I am coming back little bit. This is the most difficult part. Coming back, going into the submucosal plane. Now, same thing I am continuing again. If you go and directly dig at the 3 o'clock to 9 o'clock, you will be having problem. Later on, you cannot turn like this. So in the beginning only, get the control all around. In the beginning only, get the control all around. See, majority of the gland is moved away from the veru, away from the sphincter, on the left side of the patient, on the right side of the surgeon, on the right side of the screen. Now I will continue like this. See, this is the only bleeder as of now, and immediately it is settled. Now I am turning. See, I am coming back and submucosally I am turning this. See. This is the tricky part. This is the tricky part. This is the most difficult part. I feel rest of the things can be done. In the mid part of the gland, perforation is the second problem. See, this small piece I have left behind. Now again I am coming to the floor. Again I am turning slowly. See, by this time your mind is clear that in which direction, how much you are coming back is the most difficult part I am telling. You have to come back, then only you can go to the incision you have given in the beginning. Otherwise, this part is easy. You'll be going. but you have to come back is difficult. See, I'm coming back slowly and incising. See, that area you should not slip and damage the, see, slowly you do it. Literally, I'm doing slowly. Purposefully, I have demonstrated. See, this is the bridge at the center, connected to the bridge. I have not incised anteriorly. This is all together one gland. Now again, I am coming to 6 o'clock position. Everybody feels 6 o'clock position, it is very easy. But if you don't do this 3 o'clock to 12 o'clock position, you will be in trouble. You should do from the beginning only. See, even if you leave small gland, okay, but ultimately you will reach the capsule. There is no doubt. Without capsule, you cannot do in Holmium. Now, see, slowly, nicely curve at the 1 o'clock to 12 o'clock I am doing. Now it is getting separated. See, in this region, I had given the mucosal incision. Now you go deep and go to the opposite side. That's it. Again, I am coming down. So like this, you start at one place. Don't dig the same thing. Keep on moving all around circle. Usually tissue gets separated. Now I am going anterior. I am going anterior. See, some gland is there. No problem. After some time, you can develop the plane. Now you should attach. I made a mistake here. I might have gone to the opposite side like this only completely. I did not go. Opposite, see, in the center, I am stopping. After stopping center, I tried to go behind the retropubic region for certain distance. Now see, this is again on the left lobe of the patient with right hand on the right side of the screen. And I am separating, I am going. By this time, I might have gone to the, opposite lobe. So what I mean to say, just because you are getting plane, don't dig in one area long distance, because that area you have to in continuation with the all around clock. See, I am going happily. Nicely plane is coming. Left side I have gone. See, already bridge developed. Now slowly I have not concentrated on the right lobe at all. That's not correct. This was happily I was moving the journey. This is a mistake we do. By this time, I might have done opposite lobe also and made this plane continued with the opposite lobe. See, this is the center on the top. Now I am going to the opposite side. There is a small change in the plane. See, already. One layer I am again going deep. These are the things we should not do. I am going from reverse direction from 12 o'clock to 9 o'clock position. 12 o'clock to 9 o'clock. 12 o'clock to 9 o'clock. Already I have given retropubic region, so I am going there. Instead of doing this, if I have done the gland from the distal to proximal, it might have been little time avoided, but nothing wrong. Everywhere capsule is capsule. So I am coming from reverse direction. See, this is difficult for a right hand surgeon. See, now I have to develop a plane here. That I might have done in the beginning only. This is the mistake. See, with single hand I am rotating. This is the mistake. I am going below up. I am going below up and trying to meet the opposite side. Here I had a little problem. I will show that. This is a sphincter. See, if you have developed this bridge in the beginning, this bridge, it might have been better. So all around getting connectivity is very important. This is on the right lobe between 12 o'clock and 9 o'clock. You can appreciate this is a very, very, very important thing. I wanted to stop here and show that this is the point how, see, this is the curve I am following on the right side. This curve I might have done before. That is the what mistake I have done. So I will erase it. I will erase and then go back and start again. This is on the right side of the lobe, reverse direction. This is again second learning point. One is coming back and cutting at the sphincter is difficult. And second thing I told is long length, if you go continuously in one area just because you are doing well, meeting to the other plane becomes difficult. So I am going now. See, the floor is easy. Everybody floor feels easy. See, this is a floor on the right side. Going in reverse direction up. No problem. but you have to orient towards the curvature of the gland. That is the imagination, like in PCNL. Now, if you come back, you see entire gland is lifted. Now you are getting both glands into control. See, this is the top of the top mean 12 o'clock, 12 o'clock, 12 o'clock to 1 o'clock, reverse 12 o'clock. The beautiful plane is here. So it is going between the 12 o'clock and back to 9 o'clock, 12 o'clock and back to 9 o'clock. So I am taking pause and thinking how I have to connect here, and the whether I have to connect now or I have to go retropubic region. Now see, again, I changed the settings now. A little I increased to 50 and 20. Till now I was doing 40 and 2.0. Now, because sphincter is completely released, I am moving forward. So that is the point. So now I am cutting same direction on the top. See, this jolly-like type of thing, see here. You have to come extremely right side. During that time, if you go more right side, it may perforate. See, this is a bridge which I missed. So I am connecting now. So if you have done all around from beginning, 1 centimeter, see, this is on the again right side. This is again on the right side. I mean right side of the surgeon, again top left lobe of the patient. Now uniting to the opposite. See, this small difference has come here. Different layer we are entering. This is a different layer. You can see between 12 o'clock and 3 o'clock, 12 o'clock and 3 o'clock, 12 o'clock. Now again 12 o'clock. Small gland is left behind anterior. This is the bridge. This is the bridge I was telling. I might have united way early this. So because I continued only with one lobe, this is taking time here. So this is very important anteriorly. Ultimately, if you follow the capsule all around without digging in one area, you will progress very fast. See, slowly I connected. As I connected the right and left anteriorly, my surgery goes fast. See, I am going right forward movement. This is 12 o'clock. This is 11 o'clock. This is 11 to 12. Forward movement. Laser fiber at the bottom. Very nicely. Not, I was thinking as if I am working on a cadaveric dissection. And so much coagulation effect is there in this laser. I don't know about the other lasers, but very, very fine dissection is happening. I am also not experienced person, but I know the concept because I have done a lot of TFL enucleations. See, here is the connecting bridge, small amount of the prostate tissue. This is the capsule. This is on the top roof. See, now both lobes are getting connected easily. This is again coming back. So much time I have spent between 12 o'clock and 9 o'clock in the reverse direction. See, I am coming down. Again, I am going back from 9 o'clock to 12 o'clock slowly. Definitely, I have done slowly. Still, it took only 1 hour time. So 1 hour is a very, very meager time for enucleation. We should never worry. But there is no bleeding. See, all the glands. See, now laser fiber is tilted up. Whenever you do floor, laser fiber tilted up. Lot of time I have taken to learn this. I used to keep bottom. Bottom, if you do, see, it will perforate. Up, you can do entire surgery. Up. See, slowly plane is developing on the right lobe of the patient. Left side of the screen. Difficult for the surgeon. See. I have to go little deep. Groove. This is a groove. Peeling of the, people say peeling of the orange. This is a groove. The identification of the capsule, by this time you can clearly understand that it is white. Second thing is small gaps will be seen, and no yellow flocculi type of thing. Whereas in thulium, all this, see, this is the bridge again. So like this, you have to go and this is easiest part is this. If you want, you can increase the energy here because you don't have any sphincter. Can you appreciate? You do appreciate that there is a different plane. I have to readjust here. See, one plane, right, the left lobe I have done nicely. Right lobe, I am struggling to meet both lobes. If I have done in the beginning all around 1 centimeter, this problem doesn't arise. So repeatedly I am telling that when you go in one good plane, don't dig it completely. Surgery says plane by plane. If you are resecting the colon, if you go only one area up to renal hilum, rest of the colon will obscure your vision. One layer you have to separate the colon up to the psoas, up to the ureter, up to the hilum. Like that, see now all around I am playing now. Now I am coming to the retropubic region at 12 o'clock. Beautiful plane will be there. You can move fast, but only thing is you should not go in one plane for a long time. Now I am going horizontally. Horizontally is most easy. You can appreciate clearly the different plane. Now I got full control of the system. All around my scope can go in one go without using the handle. I can rotate. See, I am coming bottom. Bottom is 6 o'clock. This is 6 to 9, 6 to 9, 9 to 10, 9 to 10, 9 to 10. This is the mid part of the gland. Capsule can perforate here. In fact, in this case, small amount of perforation was there. Hug towards the gland. That happens only when you hold the laser fiber upper part. Now you are moving on the left lobe nicely from below up, from 3 o'clock to 12 o'clock. Now again coming to the retropubic region. See, capsule has different layers. Every time you feel that it is going into different plane. That's why all around play continuously is the secret. Just because you got the plane, don't go in one plane. Because everywhere capsule, 2-3 areas, it looks same. So you should not get tempted that you are getting good capsule. Capsule also has 2-3 layers. So all around, just see again coming to the other side. So it's a perfect circular movement of the scope, not forcible movements. See, it's again floor. If you get, see here, I wanted to get oriented back. Then this is the bottom. Bottom is 6 o'clock. And then the laser fiber is at 12 o'clock. So that capsular perforation will not happen. I am lifting the prostate in the bottom. So this is a tedious. People will not enjoy enucleation surgery till the end. But if you want to learn, you have to see like this continuous surgery. See how nicely it is separating. But don't separate it just because it's separating at the bottom. Directly it will go into subtrigonal. You have to enter the bladder anteriorly. That is at 12 o'clock. You cannot continue this. It may go into the bladder, it lift the ureters also. No. You should see the bladder. See how it is nicely lifting. You have to stop here, come back, and again go side. Now I am using between 6 o'clock and 3 o'clock on the right side of the screen, left gland. Little changed eye. See, now I am going up to 3 o'clock, 3 o'clock. See, one hand is enough, like that. This anybody will get. It's like car driving. You need not see the hand. You get adapted easily, no problem. Small scope is better. Large laser fiber is better. Low energy is better. High frequency is okay. High energy can perforate the capsule. See, I am continuously rotating. Absolutely no problem, no bleeding. You can appreciate sometimes I am going towards the gland. This is bottom at 6, bottom at 6, 6, then bottom 6, 6, bottom of the prostate is easy. The gland separates easily. Capsule is thick, but perforation can occur. Now bottom say I am going towards 3 o'clock, 3 o'clock, 3 o'clock. Absolutely I am at 3 o'clock. 3 o'clock, vertically up I am going. Now I changed direction. I kept it to floor. When you are doing at 12 o'clock, you can do at floor. You see, at one place I am not doing. To be honest, this is comparable to dusting of the stone. If you don't dust at one place stone, it will break. Like that here, continuously you should take turn. Maximum 2 minutes you can do one area. After that, you have to change the area. See, going to the opposite side from the top, coming back and uniting. This coming back and uniting is also very important tip and trick. Groove, you come back. and see where the capsule is there. See here, you have to come back, and then do it. Now this is at the top. Top means 12 o'clock. Top is easy, bottom is easy, but don't do it continuously. Top and bottom. See, here perforation has happened. You see small perforation. So I left there and I am moving from below up. See, so small tissue of fat is seen. Don't go deeper to it. Try to hug. See, I'm trying to hug the yellow area. This is the only area I've done mistake in this case. That's why I'm mentioning. See, now again I am coming to the bottom. Again I am lifting the gland. I am going below up on the patient right lobe, left side of the screen, slowly going towards the gland, so that I will not increase that perforation. Now I am coming to the bottom again. So like this, we will continue all around gland. Don't directly go and open the bladder, then you cannot come back. So all around, if you do, it will real peeling. In one area, if you dig, other area capsule will get torn. So now I am going again, reorienting myself, bottom. You cannot go in the center of the gland now. So reorienting, always reorient from the bottom. See, I am little struggling on the lateral aspect of the lobe. It's fine. I have crossed that, I have changed it to arm to the upper side. This is the perforation. So I have to be little towards the gland, purposefully. See, little towards the gland. See, I'm struggling here. This is the peak convexity on the I will show that convexity here. This is the peak convexity on the, see, like this, it's a peak convexity. This is the peak convexity. Here perforations can happen. So that is what I wanted to tell. This is on the patient right side. So now with this, I will further proceed. Now during that time, you assess the curve, go slowly and be close to the gland, not on the capsule. Now again reorienting, I came onto the other side. See, this is the rotational movements on the hand. This is nothing new. So we are going, I don't want to fast forward. I wanted to show everything. See, this is on the right lobe again, below up. If you don't see continuously, you cannot follow the enucleation surgery. It is very difficult. That's why I'm one step also I am not changing. This is on the top. Top means 12 o'clock. Top 12 o'clock. Curve lateral. So at this level, after the mid part of the gland, you can go to the bladder, so that it will be easy to rotate. Now parallelly at 12 o'clock, I am going. Now you can go fast. See, dome is coming, blueness will come. That also don't dig in one area. See, blue dome will come. Blue dome is like sky. When water is seen like sky. See, now anteriorly I have opened. This you should not do in the beginning, I feel, because you have to come back again. Now 50-60% of the gland is done. So you have to regularly, front and back, you have to unite, but not at a go. This is at top, that is 12 o'clock. 12 o'clock, 12 to 1, 12 to 1, 12 to 1 I am doing, 12 to 1 rotating, 12 to 1 rotating. Don't do this continuously in the bladder region. Come back. See, come back like this, come back. Now, this much gland is there. Now again, I came at 6. Reverse. This is bottom. Bottom is 6 o'clock. Bottom is, you see, here capsule perforating little bit. See, the laser fiber is at the 12 o'clock, not at 12 o'clock, bottom. That's why capsule is getting perforated. It should be rotated up and taken. But our tendency, because we are right-hand surgeon, we try to keep at the bottom. That is dangerous. See, what I am doing here is not correct. I am cutting, lifting the gland. But if the laser fiber is at 12 o'clock, it cuts towards the gland. That is safe. Now my speed is increased. I'm comfortable because I entered bladder. I am away from the sphincter. All around I got the grip. See, this is a right, basically right hand reverse and bottom movement. Here it is little perforated. Here. See. I am going towards the floor of the capsule. You should go like here, no problem. Lateral aspect, no problem. So lateral aspect I am doing. Now I am going to the bladder. I am going to the bladder. I will see where I am in the bladder. Yes, lot amount of tissue will be there. You should not think that by entering the bladder surgery is finished. No, lot amount of mid prostate gland will be there. So you should maintain patience. You should not increase the speed unnecessarily. Vertical length of the gland will be more. But most beautiful part is no bleeding. You go slow. If the bleeding is not even one drop bleeding, it is C, curvature between 2 to 5, between 2 to 5, between 2 to 5. So 5 cuts here, 5 cuts there. If you do, then this is anterior, then side. I mean right side of me, left lobe of the patient. Left lobe. See, this is a small bridge. You have to unite now only. Otherwise, that plane and this plane will separate. Then you cannot bridge. Again, you have to travel double the distance. So secret is don't stay at one area. Every area you see nicely between 1 o'clock and 3 o'clock, 1 o'clock and 3 o'clock. The advantage is it cuts. The disadvantage of thulium fiber laser is it chars. Then you will not know whether you are in correct plane or not. By the time you might have gone into a different plane, which appears also like capsule. See, now bottom I came. I am turning up. This is correct. This is correct. This is bottom. Bottom is 6 o'clock. 6 o'clock with the laser fiber turned up is the correct. Now see, no problem. I am lifting the gland, closely hugging towards the gland at 6 o'clock. Absolutely, there is no problem. Only thing is, you should not continue this, otherwise it will go subtrigonally. You should be in line with the bladder so that you don't cross the danger line. Danger line is the bladder neck. If you go like this, you may cross bladder neck also on the floor. If you go like this, you may cross the bladder neck also. So don't do this. And you are not digging in one place also. Continuously, I am moving like in lithotripsy of the stone. See, again, a little gland is there. You have to change the direction. So follow the curve of the, see here gland is getting cut. Gland is getting cut. I can see that mistake I am doing, but that's okay. Little bit gland is okay. See, I'm not able to press the prostate because it is a en bloc resection. Now I'm going up. I'm going up on the patient right lobe, up, reverse direction. This is a perforation which I have already mentioned. You should not deepen that. That's why I'm going towards the gland. I'm afraid because if I go continuously in that plane, water will seep in. See, I'm pushing the gland and trying to be with the gland. Now that area is over. Danger period is over. You should get away from that area. You should not make a big hole in the capsule. Otherwise, entire water will seep in that capsule. See, now I changed my direction. Purposefully, one small layer of the prostate I have left. Now see that small area of the perforation. That's all. Now again, I am coming to the bottom. So the secret repeatedly I am telling is don't just because capsule is seen, don't go in one area. You do 5 to 10 cuts in one area, then move to next area, then move to next area. All keep getting connected. See, now bladder 9 o'clock I got connected between 9 and 10 o'clock. So suddenly don't sweep it completely down. Then it is not good. Enough. Then again come to the one more area. So that entire gland peeled off equally. Not in one area you are peeling off. So this is the most important thing. This reverse direction needs experience. Doing reverse direction not necessary except in the floor. Now I am coming to the patient patient left lobe. That is my right screen. Again, I am doing 5 minutes here, 5 minutes there, so that I will do well. Now this is the picture. So this is the come back and finish that also. So don't dig in one area. See now, come back and come back and attach. See, come back and attach. Yeah, this is the process. Come back. If I have not come back, there might have been a big difference. See, at any point of time, not more than 5-6 cuts, and then connect to the other area, next area. So if you are doing now 1 to 3 o'clock, do it for 5-10 cuts. Come back and go below. See, this is below. This is 3 o'clock to 5 o'clock. 3 o'clock to 5 o'clock. See, some gland is C. Now we connect this bridge. Connect this bridge. Connect this bridge to the top. See, already it is little difference is there. Connect that immediately. Again, you are pushing the gland into the see. Now this is again I am doing between 3 o'clock to 1 o'clock. Connect. Come back and connect. See, connected. If it appears difficult, but you will progress. If you go in one area just because you are doing well, you will get stuck. Here also one important area, you may perforate and lead to bladder neck stenosis because bed will not be there. See what I am doing. Coming back. Back means out distally. That is very important in enucleation surgery. Coming distally out. See. That curve I united. Again coming down almost at 6 o'clock. Again going back. Like that, if you keep on sweeping all around, then entire gland last will immediately finish. See, I am so comfortable. I am at the 6 o'clock now, between 5 o'clock and 6 o'clock. This is dangerous. This is dangerous. This type of hollow, if you see, it is not good. Nowhere you should see hollow. You should see capsule. Hollow is perforation. See, this is hollow. This is perforation. Now I am trying to rectify by going up. Instead, I might have kept the laser fiber up. This is the bottom actually. Bottom is what? 6 o'clock. See. I am confidently moving, but I am going deep. Now again, I come to the bladder neck region. I rotate on the capsule. If you go more laterally, perforation will happen. Multiple perforations leads to fluid absorption. See, this is a perforation. Clearly, this is a perforation. Fluid absorption and then fluid overload. Quickly correct it. You will see that fat, whenever PCNL you perforate, fat lesions you will see. Whenever you perforate ureter, fat thing will be seen. Same thing here also. See, small granule flat type of. Now again, I am at the floor. Floor means 6 o'clock. 6 o'clock. See, it's perforating. I know that it is perforating. This type of blue should not be seen. This is wrong. So slowly I am going to the opposite side, pushing the gland. This is wrong because the laser fiber should be at the top. So my temptation towards bottom to do fast is always there. I have to rectify that. Even though in this case, see, this we might have kept the laser fiber at the top. When you come side and anterior, you can come to the bottom. So this is a basic point. See, big perforation here, big perforation. This might have easily avoided by see, now to avoid that, what I am coming is that from 3 o'clock, I am trying to finish at the bladder neck and get that capsule intact for me. So that intactness I am here. That intactness I am getting here by going close to the see the big perforation here. Capsule is very thin at this. You should go up. Yeah, here it is up again. This if I have done, I might have hugged the. This is at the bottom. Bottom is 6 o'clock. See. I am hugging at the top. This is the basic thing which I made mistake. 1 or 2 mistakes I made in this case. Fairly okay. Now, the bottom. Bottom means 6 o'clock. I am operating at the 6 o'clock. So my laser fiber is playing at the 12 o'clock. See, this is the perforation I did at 5 to 6. 5 to 6. Once you come here, you have to turn the laser fiber down. That is a problem. That turning laser fiber down and up should be careful. Somebody is experienced, they can do in whichever angle. But the basic principle is you are doing with 30 degree. So for 30 degree bottom, that is 6 o'clock, camera laser fiber should be up. See, up. Now this is correct. If it is 6 o'clock, you are operating with up laser fiber, you will not have any problem. This. See, now I changed my direction. I hugged the prostate gland. I am developing 1 millimeter superficial plane so that I will not perforate. This is the last 5 minutes of the. It is a boring surgery. After some time, you lose concentration and you feel that TURP is very easy, but definitely you need perseverance to learn this. Once you learn, I am feeling that now I am using only around 10 bottles. Into URP, 8-9 bottles. Sooner I will save more in HOLEP than it took long time for me, watched videos, watched surgeries, but I never had the mission. Now I have the mission, so I am enjoying this. And this can be done with 60 watts also. See, we are using 100, but first 3-4 cases, we see here I changed the plane because perforation was happening. That change you can do only when the laser fiber is at the top, when you are doing at 6 o'clock position. Multiple times I am telling that. This is the ABCD. For senior, this video is of no use. For learners, even I am learning. So I thought whatever mistakes I have done, I am sharing. That is a ABCD. Now see, now I came out and again I reinserted. Now this is the patient left lobe between 3 o'clock to 4 o'clock, sweeping like a hockey stick incision. Hockey stick, this is hockey stick. Developing new plane so that, see, here I made a mistake. I mentioned again and again. I am hugging the gland here. See, the air bubbles will come when the bladder bottles get empty. That time don't operate, just stay for 1 second. It will, see, I am changing the plane here a little bit. This is the tricky part. This is the tricky part. Here is the tricky part. You have to take certain gland with you. Otherwise, that perforation will make a hole. Then you cannot come up. So any hollow like black thing you should not see in the, say it should be like this. It should be like this. See, slowly I am changing the plane. Laser fiber at the top. Surgery is at the bottom, 6 o'clock. 6 o'clock. See the perforation. This is, but I crossed that perforation. Again, I am going to bladder. Again, I am doing the hockey stick incision. From the bladder, while coming, come like a hockey stick. This is the vertical part of the stick. This is the hockey, this stick. So now I am coming to bottom of the gland at the bladder neck, but not at the mid part of the gland. That I have to correct now. See, I am correcting. I am correcting that perforation part. I am pushing the gland a little bit. Again, I am going to bladder. So I want to avoid that perforation to increase. So better not to do perforation. This perforation happens when you see now new plane developed. See. New plane developed, and this is on the patient left lobe and right side of the screen. See, this perforation is abandoned. Discontinued. One layer above that I entered. Now safe. That is possible with hockey stick or laser fiber up. See, now new plane has come with some small gland left at the floor. Finished. Now I am very safe. That is because of hockey stick. See, go inside, distend the bladder so that you now come back, sweep like hockey stick. That is the plane. Hockey. This is the hockey curve. Hockey stick curve. Now, see how nicely it is getting separated. Now again I am going inside. This is the vertical stick of the hockey. Now you are turning part of the hockey. Now again. So slowly I am finishing the gland. Nicely it is cutting. So this you should do from the bladder to the mid gland, not mid gland to the bladder. Otherwise, you can go to anywhere. With this, you can avoid the ureteric injury. See, now almost opposite side I have gone. Once you go to the opposite side, no issue. The gland will be tilted. See, now this part we are doing. This part. See, this is the some gland. Leave it. Leave that gland. No problem. It's like one chip perforation may happen. Developing a good plane, enter into a new plane of the capsule like this. Like this. Again, from the bladder, you can continue that. This is exactly at 6 o'clock position, last part of the, see, like that, like that, like that. You go to the bladder again, slowly make hockey stick incision, come back, come back, come back, like that. See, small amount of tissue was there. Again, go to the bladder. This should be done only in the last part, not when the gland is not separated. Only when gland is 1 centimeter left behind, you can do that. See the fastness. I could understand that it is finishing now. The gland is getting lifted off and going into the bladder. Now there is no problem whether the laser fiber is bottom or away. This is hockey stick. Entire surgery is hockey stick once you reach the bottom. So that first bladder, then gland, whatever left behind. See now this push, it will double fold and go inside. Now again, see, again I am depending on the hockey stick type of this thing, sweeping horizontally the entire gland and getting the gland into the bladder. So dear friends, we are coming to the end. Never dig in one place. Laser fibers are always at 12 o'clock when you are doing at 6 o'clock. When you are doing 6 o'clock surgery, laser fiber should be at 12 o'clock of the screen. These two things, if you remember, the perforations won't happen. Do slowly. Energy is 2 joule standard. Frequency is 30 to 50. Frequency is for fast, F for F. Energy is for thickness, perforation, thick tissue cutting. So energy rarely we cross 2 joules. And frequency is variable. In the middle part of the gland, when you wanted to do fast, you can increase the frequency. For example, here, if you want to cut this fast, you can increase the frequency. No important structure. During the sphincteric region, reduce the energy to 1.5, 1.5 like in stone. So then you will not injure the depth. So energy is to be reduced when you are doing at the blood, the veru and see, now I am turning back, last part, forward right angle is more useful. So this, don't try to go into the bladder, be towards the, that's all. See, at the end, I have not coagulated at all. Single bleeder is not there. This small tissue you fluff off, you can coagulate or you can just throw it out, it will come out. They are very small. Now immediately I will take out and go and see again. See how beautiful the sphincter is. This is the best part. Absolutely no incontinence. See, all around. There is only hardly any bleeders. One bladder neck. This is the veru on either side. And then this small tissue, Good. This tissue should be left behind so that incontinence will not be there. Now I will exchange with the, see, this is the gland, complete gland. Now this is the morcellator. Nephroscope is used. Biorad morcellator we are using. It is suction power. Actually, 3 minutes morcellation is over. Around 70 grams it has come. Total reported is 100 grams. Honestly, every time 100 if you tell, 70 only will come. 70 means 40 will come. 40 means 20 will come. That is for sure. 40 grams looks small. We have one more video today we have done where 40 grams was there. Even then enucleation can be done, but TURP is also easy. TURP is very easy, but TURP bleeding happens. In enucleation, if you are in a good plane, bleeding is very less. In this case, I must tell, you are watching the video, you don't feel any bleeding. 1 or 2 bleeders also rarely seen. So this Morcellator secret is, where the blade is, it should be facing up. Total black background should be there. One person should put the hand on the abdomen. Basic ABCD this is. Black, see, you see black area. You should not see any bladder. Black area backside indicates full bladder. And blade should be up. And a lot of patience. Engage properly. See, it's a slipping. It's an en-bloc specimen. En-bloc specimen is more difficult. See, it is slipping. So attach it slowly and then do it. This happens. See, still it is 1. Smooth surfaces, it won't get trapped. It is boring. By the time you get exhausted and you will not see, nothing is happening here. Just pressing. So again, reposition. See the blades above. Can you see the blades above now? Turn towards the gland like that and then start. And then start. See, now it again taken up. So one raw surface will take better than a smooth surface. See, this is a smooth surface. That's why it is not taken. That's why I did not change the editing part so that you see all these problems. Slow. When things are moving away, when the gland is moving away, slowly you empty, apply suction first, let it engage, slowly press the button. In between it will slip because the Morcellator speed suction coordination may not be there. But luckily, if you have not broken the pieces, it is lucky. It's like a large stone RIRS. If you break it into 2-3 pieces, then you have to attract 2-3 pieces. If a large piece is there, see it hangs on there by gravity. Some people say, pull it towards the bladder neck and do it, it is better. But some people say inside the bladder neck you do better. Some people say after 1 day also you do better because it gets marinated. But patients will not accept to go again inside with anesthesia. That is very difficult to convince the patient. Somehow I have not postponed. I have not done more than 150 grams because I do robotic simple prostatectomy more than 150-200. But this up to 150, I think Morcellation should not take more than 15 minutes. But one thing is there, if the bleeding is there, see in this case, absolutely bleeding is not there. That's why I've selected this case. Otherwise, why will I show this? Because I have done very well. I have shown this case. Sometimes hiccups will come. So I take monopolar or bipolar TURP instruments, coagulate in the beginning period, nicely coagulate, and then introduce the Morcellator. To have this good vision, you need absolute hemostasis because in a nephroscope or marcelloscope, flow is one way unless you press suction. If you don't apply suction, flow is one way. RBC will not come out like in Foley's catheter, 3-way Foley's catheter. So last part is more irritating. This becomes 2 pieces, then it is really irritating in a big bladder to get them back. So it's single piece, it's going on, luckily. When the round surface is there, floppy areas are there, it leads to floating and real frustration. Sometimes I take forceps, triprong, and then do that, triprong forceps. See, it has become 2 pieces. Now, a little frustrating, especially last piece like this. But Biorad, this Tommy is good in suction, very good in suction, and it sucks well. And when it sucks well, it morcellates well. If the suction is deficient, you have to empty the suction apparatus, clean the blade, if any soft tissue is struck. These are all very important. I cannot show all that. See, such a big distended bladder with tegaculated, and if the piece moves here and there, you get frustrated. And it will take time. Sometimes it takes half an hour, more than enucleation time. No, we can't do anything. You have patience, don't suck the bladder because you are frustrated. Take time, apply suction, see it going away. You chase it, again it is coming, again it is going. So a little bit of patience, but keep the blades up. Let the sea be there. Backside sea, nothing is seen. It's a sea of water. Then you will not see. That's the end of it. So this is the complete surgery. So I tried my level best in this 1 hour surgery unedited to express my surgical technique. If any questions can be taken, otherwise, after a long time, I am myself discussing a technique because I am sharing already videos. I am not involved as a speaker. Today I thought because I am learning and I am enjoying this enucleation, I thought I will spread the knowledge. And in this month, we have very important talks. We have this is the 5th anniversary of Pure Urology. Ravindra Sabnisar, who has started first topic, is going to give on 23rd, 25th, one talk, that is common mistakes we do in PCNL surgery in periphery. That is the anniversary talk. Please do not miss. And you tell your urology friends. There is no point non-urologist or general surgeon joining the program. It is of no use. We are not allowing urologists who are certified like MCH, DNB, join the program. Discuss the cases with surgical technique based, not theory based. Discuss multiple complications so that this large fraternity of 12,000 people will get benefited. Thank you once again for giving the opportunity. Thank you. We will end the session.